All right, I'll get you to move on to the next slide. Uh, so what I want to do today is give any updates that we have had from the Society of Maternal Fetal Medicine through June 16th. There's not any updates since that time, but really going to look at labor and delivery considerations as well as just management considerations for pregnant patients with COVID-19. Next slide, Rachel. So before I do that, just an update on the status of COVID-19. I think everybody realizes that the number of cases are really increasing significantly. This data is through the weekend. The U.S. set a single-day record on 625 with over 1,000 new cases. Through Saturday, we had almost 2.5 million cases with 119,000 plus deaths, about 4.7% death rate. In South Carolina, we're one of those states that doesn't want to be left behind. We're leading the forefront with COVID positives. On 627, we had reached a new record of over 1,500. I think yesterday we reached over 1,700, so another new record. And the South Carolina total through Monday was 34,546. Good news for us is only a 2% death rate here in the States. We're one of the lower death rates reported across the country. CDC reported some data from quite a few pregnancies and just general population doing antibody studies on patients across the board, and suggest from that data that the likely infection rate is 10 times higher than what we have found by the PCR testing. So just as we suspect, a lot of asymptomatic infections based on antibody tests. Next slide. So to do with labor and delivery, general guidelines and general principle, the high-risk OB scenarios that we suggest N95 for any suspected aerosolizing procedures such as bronchoscopy, intubation, open suction, what likely being done or scheduled to be done. Examples would be if you're doing a cesarean section, a twin vaginal delivery, transferring the patient to the OR for management of postpartum hemorrhage or intubation for any other reason in the pregnant patient. The second stage of labor and other episodes of deep respiratory effort seen on labor and delivery, we know if you've got a COVID positive patient, should use an N95 if available. If not, face mask is certainly fine, but use eye protection, gloves, and gown. Now, this is a hot topic of debate. Obstetricians are quite vocal in the need to use N95s if you're doing a vaginal delivery for a COVID positive patient. The bottom line, the data does not show an increased incidence of spread at a vaginal delivery, and thus the CDC says face mask, surgical mask is appropriate if an N95 is not available. We do use N95 here for vaginal deliveries and positive patients, but again, it has not been proven to be necessary in those situations. I always put this at the bottom of the slide: proper donning and doffing and N95 fitting is very important. And here at our hospital, we have our Gestapos, our nurses, watch us to make sure that we do proper donning and doffing. Very important. You can blow the whole thing if you don't do it properly and haven't gotten any benefit from the careful interventions that we do. Next slide. So labor and delivery, you need to coordinate with hospital practices regarding their outpatient screening for the pregnant patient with exposure or symptoms of COVID. Third trimester and breastfeeding moms should be prioritized in screening algorithms. as positive results obviously alter the clinical guidance. We're very liberal here about our testing for our pregnant patients, but particularly in the third trimester when it impacts exposures on labor and delivery, as well as exposures to the increased staff with babies as well. So very important. Next slide. So each hospital and clinic should be familiar with what your turnaround is. Use of antisteroids is continuing to be suggested for fetal lung maturation up to 34 weeks, but rather than doing steroids after 34 weeks, we've at least decided, our institution and SMFM supports this, just foregoing the use of steroids at that 34 to 36 gestation. Mag sulfate for neuroprotection is certainly appropriate to use, but if a patient is COVID positive and has respiratory depression already, be careful with it because it can worsen the respiratory depression. And we say use ultrasound judiciously because of the duration of exposure of the ultrasound. The ultrasonographer is in the face of the patient basically doing the scan, so you need to try to use ultrasound just as it's needed. Next slide.
And hi, I apologize for interrupting. I can't pull up to see everyone's screen because I'm recording, but for those who just joined, please mute yourself because we are recording this session and it's creating feedback. We really need for everyone to make sure they are on mute. Thank you.
Internal monitors for scalp leads for the baby, intrauterine pressure monitors, certainly use it as needed. Amniotomy can be used as clinically needed. There's no clinical reason that you can't do that. There's no increased risk of transmission to the fetus from information that we have thus far. Operative vaginal delivery is safe. We do ask that you at least consider performing operative vaginal deliveries in the operating room if it's not being done urgently or emergently, just because transferring a patient to the that's positive for COVID in the process can be difficult, so it can avoid those transferring nightmares for a patient that's positive. Again, mag sulfate can be used as needed, particularly for preeclampsia with severe features. Just be aware of the respiratory depression. And we do suggest epidural for labor to hopefully mitigate the need for the tracheal anesthesia if an emergency C-section did. Other things, consider suspending nitrous oxide for patients with COVID. There's just insufficient data to say whether it's safe. There's some information that suggests that there might be worsening of their respiratory status long term with use of nitrous. It's also suggested to suspend oxygen use for fetal indications. When we put oxygen on patients for abnormal fetal heart tracings intrapartum, obviously use it for maternal hypoxia, but not necessarily for fetal indications, as frankly, the data has never shown an outcome you putting oxygen on for an abnormal fetal heart tracing. Next slide. And then in the postpartum situation, use hospital guidelines. I mean, every hospital should have a management protocol for dealing with their babies and moms that are COVID positive. There are very nice directions on the CDC website that have been adopted by the AAP as well. So I would encourage you to review those if you don't have a policy for your hospital. Next slide. So as far as the diagnosis and management in pregnancy is very similar to the non-pregnant patient. We're a little bit more liberal about testing those pregnant patients because it does affect two people and a large staff. Moderate disease may require more liberal admission in pregnancy as compared to non-pregnant patients, and we'll talk a little about that later on. Next slide. So moderate disease is defined as lower respiratory disease. They have signs and symptoms of dyspnea, pneumonia on chest x-ray, refractory fever, and their O2 sats are 93%. Next slide. So severe disease, again, is lower respiratory disease, but the signs and symptoms are worse. An increased respiratory rate of over 30. They have a more significant hypoxia with O2 sats less than 93. And on chest x-ray, over 50 of the lung fields appear to be involved. Next slide. Then the critical disease is when you start to see multi-organ dysfunction, shock or respiratory failure requiring either very high flow nasal cannula oxygen or mechanical ventilation. So these are the patients that fortunately we don't see nearly as often. Next slide. Our goal for pregnant patients is to maintain them at home. Admission is very often needed for maternal and fetal well-being if you're worried about their symptoms being more significant. And I will say we admit these patients a little bit more liberally than we do non-pregnant patients, but the key is to maintain safe outpatient management as long as we can. Next slide. The precautions we give for the patients, we're on the phone doing our video visits for shortness of breath, tachypnea, unremitting fever. When they can't keep their fluids down, that's a big indication that they need to come in to be seen. Worsening pleuritic chest pain that's persistent, doesn't get better. Obviously, if they have cyanosis and any preterm labor, bleeding, increased fetal movement, we have those patients come in. Next. Admission criteria, without a doubt, moderate to severe signs and symptoms. That is that severe shortness of breath. And a lot of times really hard to tell over the phone or on video visits how the patient is doing, but we do the best we can. If they're being seen and their O2 sats are less than 95, that patient gets admitted. If they have significant comorbidities, and the comorbidities that seem to have a significant impact on these patients, diabetes, pre-existing diabetes, and hypertension, and even obesity, those three. Refractory temperature of over 102.2, another thing that may require. The next slide. Inpatient care, we try to maintain their oxygen levels over 95%. Careful hydration. When these patients are sick, you can overhydrate and lead to third space fluids, which can be disastrous. So you have to be very cautious. Treat the fever, just supportive care, and fetal monitoring with TOCO as well. So early warning signs in these patients are when they have that deep sensation of dyspnea and they're having to work hard to breathe. And you can tell that when a patient can't really talk to you as they're trying to breathe. They can't maintain their O2 sats on room air. Persistent and more frequent and higher fevers. And the other thing is kind of worsening myalgias are common with patients who are getting worse disease. Next slide. So there are lots of scoring systems. Not going to go over this, but these are the sepsis scoring systems that we use. Our colleagues in critical care might use them more than we do, but they are utilized particularly by our multi-specialty teams. The next slide, I just have this slide inserted to help understand that we in obstetrics may admit patients a little bit more quickly to the ICU than we would if they were non-pregnant. In other words, we put our patients on our COVID unit here. They're starting to exhibit evidence of worsening dyspnea rather than waiting for them to desaturate to transfer them to the ICU. In the pregnant state, we will very frequently move them a little bit sooner and then just move them out earlier if they don't need to be there. The next slide. The key with ICU care is the multi-specialty approach. We obstetrics don't have nearly as much to do with it, although we're monitoring this baby and mom, helping the ICU team. But the critical care docs and ID docs are important to helping these patients. Convalescent plasma and antivirals are used in these patients and has been used safely. There are registries that are ongoing documenting the safety of these, but there's no reason that we wouldn't use them. The intubation criteria are the same as they would be. We probably intubate a little bit more liberally in these patients because we don't want them crashing. Intubate when a patient is deteriorating makes it much more difficult, and it also puts the healthcare providers at greater risk as well. So we try to do it in a very controlled situation. And delivery options are wide and varied depending on how the patient is. We will frequently deliver these patients earlier if they're having respiratory distress with acute COVID management. Next slide. So the timing of delivery is really benefit risk weighing. If a patient is 34 weeks for sure and worsening, we deliver those patients. Dr. Johnson and I've talked, and several colleagues across the Southeast about other patients, and we've kind of drawn the line in the sand that if a patient is beyond 32 weeks with severe COVID respiratory depression, that those patients deserve delivery early after steroid administration. It allows the respiratory to improve and they just recover more quickly. Next slide. Controversies, the number of antenatal visits with positive patients. The guidelines actually say a call a week in our office. If we have a COVID positive patient, we're calling those patients 2 to 5 times a week. We do drive-through visits. If it's a high-risk situation and the patient needs antenatal testing, we have them come in our back entrance. We have them come in the end of the day, and we do a deep cleaning after they leave the office. The first and second trimester are much more easy. You can spread those visits. Third trimester, a little bit difficult. You can certainly alter the visits early, but later in the pregnancy, you just got to see the patients. Delivery timing, we talked a little bit about the premature ones. Patients who are doing well, they have just the mild symptoms of COVID or asymptomatic. We try to push them until they've had the 10 days past the positive test to do an elective delivery. Let's say a patient comes in at 39 weeks. If they're doing well, have normal amniotic fluid, good fetal movement, we'll push that patient to 40 weeks to deliver or more. As far as routine labor and delivery admission testing, we don't do that here. I know they have done that in Charleston. We just don't have the rapid turnaround test in sufficient quantities for that. We're now testing our preterm labor patients that come in. If it looks like they're going to progress, we do rapid testing. If they don't seem that they're progressing, or we have antenatal admissions, we're doing the other test, which takes 24 hours to turn around, but certainly another option. And follow the CDC guidelines for follow-up of positives. We had been doing repeat testing, but now we have gone to the symptomatic approach, where if a patient is 3 days since recovery and at least 10 days have passed since symptoms first appeared, we will see those patients in the office. We try to wait 14 days to give us a little bit of cushion, but we have fallen back to the symptom-based strategy that you can find on the CDC website. And I will stop there, Rachel, and we have our presentation after this.
Thank you so much, Dr. Campbell. And again, just asking for everyone to make sure they're on mute to reduce the feedback. Just want everyone to know that you will be able to find Dr. Campbell's slide set on our website, which you see stated here. And our upcoming topics, we will be back on July 15th to discuss infectious disease. And then we will, on August 5th, be having a panel discussion with several different stakeholders for pregnancy wellness to discuss how the coronavirus public health emergency has affected our state. And following that, our series will be covering substance use disorder in pregnancy. And 1 second, please.